today we'll continue for the next maybe 20 minutes our topic of insomnia. We started with the definition of insomnia and the criteria of insomnia, then subtypes of insomnia. Now we will talk about how to assess a patient with insomnia. It is very important because as we will see, the most important tool to assess a patient with insomnia is a very good detailed sleep history. It's very important. Okay. The first slide is not related to assessment, but it is very important slide. I think because we have a case who have a problem. He has past history of obstructive sleep apnea and excessive daytime sleepiness, has a lot of problems, and he diagnosed somehow in Ibn Sina as having epilepsy, and he is receiving 3 different types of anti-epileptics. And to be honest, we don't know if his sleep problem is secondary to these medications. What's wrong? He also have depression. Yani, it's a very interesting case. So this slide, if you can tell, these are the medications that could induce insomnia. So if you give a patient a sedative or hypnotic, at least you need to know what are the medications, even non-psychiatric or non-neuro psychopharmacological medications. As you see here, for example, lamictal or lamotrigine as an anticonvulsant can induce insomnia. Antidepressant, bupropion, which is Wellbutrin, protriptyline, fluoxetine, citalopram, escitalopram, venlafaxine. A lot of medications of antidepressants could induce insomnia. Beta blockers, and I think if you have a patient with panic disorder, most probably you can prescribe, for example, escitalopram, Cipralex, in addition to Indral or propranolol as a beta blocker. So you know that both medications may induce insomnia to the patient. Because simply, if a patient come complaining of insomnia secondary to medication, simply you can switch to another medication, or at least you will explain to him that this will be temporary until you stop the medications. Substances, caffeine of course, and alcohol. Alcohol is very interesting. Most of us know that when you start taking alcohol at the beginning, it can initiate sleep well, but the problem is on continuation of taking alcohol, it will lead to sleep maintenance insomnia. That's to say interrupted sleep all through the night. You can start your sleep or initiate it normally, but the problem that the sleep will be interrupted at night. Also, as we see, steroids, of course, decongestants, bronchodilators, stimulants like methamphetamine, modafinil. Of course, we use these medications for excessive daytime sleepiness. Interferon, immunosuppressive agents, some antibiotics and antiviral. The most important thing again is to remember that we have a lot of non-psychotropic medications that can induce insomnia, and you know that most of our patients, especially at old age, they have comorbidity with other disorders. If we move to, yes. As I told you, to assess a patient with insomnia, it is very important to have a good sleep history. It's very important to have good sleep history. Of course, the sleep history, not in detail, but first of all, we have to define primary complaints. Is it delayed sleep onset, sleep maintenance problems, frequent awakening, or early AM awakening, which we call it premature awakening, or non-restorative or non-refreshing sleep or poor quality sleep, as we said before. Define time course of complaint, age of onset, precipitating event or stressor. Pre-sleep conditions, we can call it sleep hygiene. Pre-sleep conditions, pre-bedtime activities, bedroom environment, physical and mental status before sleep. Nocturnal symptoms, awakenings, physical or mental symptom including snoring or body movement. This is very important. Sleep-wake schedule by patient report including variability and naps, and this is by the sleep diary, as we will see. Daytime function, consequences of insomnia, sleepiness versus fatigue, impairment of mood. I think we talk about the next day consequences. Daytime activities relevant for sleep, sunlight exposure, exercise, napping, work schedule and disturbance, caffeine, alcohol intake. Medical or psychiatric condition, medication that may affect sleep, as we discussed early. Medication that affect sleep, or chronic pain, by the way, which is very common. A lot of patients have arthritis, have autoimmune diseases, rheumatoid arthritis, whatever, that it will lead to chronic pain, and this is maybe the main cause for insomnia. Okay, in addition to sleep history, physical and mental status examination, supportive information. As we said, this is very important as a supportive information. Sleep or mood questionnaire, Epworth sleepiness scale. I think this is for excessive daytime sleepiness. Most of us know that. We ask the patient 8 questions about the possibility of getting sleep in 8 different situations. Dysfunctional belief and attitude about sleep. I think I let you see this one before. Pittsburgh Sleep Quality Index, I think we have it also. A sleep log for 2 weeks or sleep diary, attention to sleep and wake time variability, general pattern. Actigraphy, and to be honest, actigraphy in insomnia is not that much important. Okay, what is actigraphy? It is a machine like a watch. You can wear it on your something like this watch. It will record everything, but mainly the movement and the if the patient is sleeping calm, quiet, or moving too much. And it's of great importance, I think, in circadian rhythm sleep disorders. Very important. Sleep study, not routinely indicated. And I think this is very important, that sleep study not routinely indicated. PSG is not routinely indicated when concerned that another sleep disorder such as sleep apnea is suspected. Maybe yesterday one of the 2 patients we talk about, or I did it yesterday, polysomnography, both of them have complaint of insomnia. One patient of them discovered that he have mild obstructive sleep apnea. So as we said before, insomnia could be due to other primary sleep disorder like apnea, like restless leg syndrome, or circadian rhythm sleep disorders. Okay, so it's very important. Also, there is another importance for PSG. If the patient have poor quality or non-refreshing sleep, through polysomnography, you will discover that the patient lacking deep stages of non-REM, which is stage 3 and 4 or N3, that this will indicate that the patient sleep only in the light stages. That's why he had poor quality sleep, because he must spend, yes, he must spend 25% of his total sleeping time during deep stages. Okay. This is again the dysfunctional belief and attitude about sleep. I think we have a printed copy. If not, I will. Okay. Okay. Great. Okay. Yes, and this is the Epworth sleepiness scale. The dysfunctional, as I told you, about 16 questions. Epworth sleepiness scale is very simple, as you see. It's very important. 8 questions or situation, usual way of life in recent times. Do you have a tendency to sleep while sitting and reading, watching TV, sitting inactive in a public place, as a passenger in a car for an hour without a break, lying down to rest in the afternoon when circumstances permit that, sitting talking to someone, sitting quietly after a lunch without alcohol, in a car while stopped for a few minutes in traffic. Each of these you will give from 0 to 3 as it's supported here. Normally from 0 to 10. Above 10, this means that you have tendency to sleep. Okay? This is important. This is a sleep diary. The sleep diary, as you see, it is a 2 different color, the light color and the dark one. The light is complete before bedtime. This is very important. This side, it will be complete in the morning. Everything is obvious in the sleep diary. This is very important to be filled 2 weeks before the patient came to the clinic, simply to know or to take a hint about the sleep pattern of this patient. Simply to discover, in addition to the questionnaire, we talk about dysfunction and attitude, or disbeliefs and attitudes. It's very important to know the sleep pattern and the poor sleep hygiene that need to be improved or corrected. This is also I think a summary for the sleep diary in a practical way to see the sleep pattern through as seen here about 8 days or 9 days. Simply when the arrow down is the time the patient is in bed. The X is the as it occurs, lights out, trying to sleep. The horizontal arrow is the period of sleep, the actual period of sleep. The upward or ascending arrow is when the patient is awake. Simply, without getting if we see this patient, we will notice a very important thing. I think this is normal individual. If you see the horizontal arrow and the onset of sleep and the awakening become late during weekends, Fridays and Saturday, okay? As if this is the weekend. Simply, we all wake up early in the morning every day except during the weekend. So just from looking at this 8 or 9 days, you will discover that this patient in particular, most of the time, they will sleep nearly at the same time and wake up at the same time, except on Friday and Saturday. So it will help us to know the pattern. And also, most of the time, 5 days, the arrows on the right side, it include the afternoon naps. Okay, that he not regularly have naps every day, but at least most of the days he used to have afternoon nap. If the patient cannot sleep at night, one of the instructions given to the patient, simply stop taking afternoon naps. You will suffer for the first few days, but after that you will get a very sound sleep at night, and you will get rid of your insomnia, simply, without giving any medications or anything, okay? So sleep diary is one of the most important things. This is nothing except that I think it is better to see in our machine, but this is polysomnography. Of course, it's as you said, as you see, there are a lot of EEG channels until the blue colored line. This is the electroocculograms. Then, as we said, chain EMG for muscle tone, then ECG, and a lot of other things, tibialis, oxygen saturation, everything, okay? We can, I think, better to see it in our machine. Most of us know what about the channels used. As I told you, the routine or the typical polysomnography is indicated if we have doubt about the cause of insomnia, if it is sleep apnea or restless leg syndrome, so we have to do polysomnography, or if the patient lacking the deep stages of non-REM that lead to refreshing sleep. These are the changes that will be found in patient with insomnia. Increased sleep latency. Sleep latency is the period from the patient going in bed and lights out until onset of sleep. Normally supposed to be less than 30 minutes. If increased than 30 minutes, this means that the patient have at least difficulty initiating sleep. So increased sleep latency, decreased total sleep time, of course, because it is quantity. Decreased total sleep time, decreased sleep efficiency. Sleep efficiency is calculated by multiplying the actual total sleep time divided by the time in bed multiplied by 100 percentage. Normally supposed to be 90% or more. So if it is below than 90%, the sleep will not be efficient. So sleep efficiency, we will divide time in bed, total sleep time, suppose it is 4 hours, divided by time in bed, suppose that it is 8 hours.
So Dr. Tarek, if somebody comes with a sleep efficiency 85.
Yes.
For 3 months.
Yes.
We can identify.
In addition to other things, it have a meaning. But if it is alone, of course, it is very mild and you can consider it normal. But in addition to the rest of the findings, it will get importance. Increased stage N1. N1 represent 5% of the total sleep time, which is stage 1. It will be increased, the percentage of it, above 5%. Decreased stage N3, deep stages, stage 3 and 4, for refreshing sleep, it will be decreased. Okay.
How much is
So normally, if it is below 20%, this is not good. Increased REM latency. REM latency normal between 90 minutes and 110 minutes. That's after onset of sleep. The first REM period supposed to be after 90 to 110 minutes. Okay, it will be increased or decreased only in depressed patients, because depressed patients may have insomnia, secondary or comorbid. Depression in general decrease REM latency. Okay.
بيخشوا في الريم اسرع. ما يستنوش ال 90
بالظبط.
دكتور طارق N2.
وات؟
في ال N2
لا في ال N2 لا غالبا ما بيبقاش فيه قوي. هو regarding N2 stage N2 or stage 2, normally it is 45%. It may decrease slightly because stage 1 increased, and it may not affect it because simply stage N1 increased but stage N3 will decrease. Okay, and REM also so it may remain constant or slightly increased. Okay.
Can you repeat the معادلة مالت sleep efficiency?
Sleep efficiency. We will divide total sleeping time divided by the time in bed multiplied by 100. It is a percentage. So if the patient spends sleeping 4 hours while he stay in bed for 8 hours, so this means that sleep efficiency is 50%. Okay? Okay. That's it. So now, to summarize, I think it's very important for us to take good sleep history for patient with insomnia. Sleep history must include any psychiatric, any medical disorder, and the types of medications, because some medications, as we explained, maybe induce insomnia by itself. After that, we have the help of questionnaires, and I mentioned 3 questionnaires in particular. We need the sleep diary, and the patient will write 8:30, 7:30, blah, blah, blah. We have this, you put it in the arrow. We are put it in that way. So it is by the look, just to look it, you will know the patient's sleep pattern, how it was in the last week or last 2 weeks. It's very important.
People with short sleeper, like less than 6.
Sometimes 3 to 4 hours.
Maybe they come here and complain I have insomnia.
That's why the first lecture about insomnia, I insisted that insomnia is not only about quantity and the quality. Suppose the patient have these complaints while the circumstances are okay and convenient for sleep, and there must be next day time consequences. If the patient sleep for 4 hours at night only, and next day he is perfect, this is not insomnia. If he is sleeping 4 hours because there was construction or there is a problem or stressor at home, this will not be diagnosed as insomnia. Okay? So short sleepers, by the way, they will have concern because they hear in the media and all their friends that you must sleep from 6 to 8 hours, especially 8 hours at night. So he come to you, I only sleep 3 or 4 hours and everything is okay. Is it insomnia? No, it is not insomnia. But simple, like if you have some obsessive traits. For example, most of us, after closing the car with the remote, you do it once or twice after that. Okay, this is not OCD. I cannot diagnose. There is no impairment. There is no wasting of time. It's just a trait, and life goes on. Okay, I'm afraid that I'll be in the elevator. Okay, if you want to go to the fourth floor, floor number 40, you will use the elevator or not? I use it, but I feel some discomfort. Okay, so you are not a patient with a specific phobia. It is the same.
Dysfunction.
Yes, 3 to 4 hours. Without any next day time consequences, it's okay. Yes. Even for 2 hours. That's why in the international classification of sleep disorder, they call it normal variant. It is a normal variant. Okay? Thank you. There is any question? Inshallah, next Monday, Sunday at 11:30, we'll continue the neurobiology of sleep, the areas and the neurotransmitter responsible for that. Monday morning, I think it will be important for us. It will be a lecture, no meeting. Monday morning, if you want to make it 8:30, if you want to make it 11:30, no problem for me. It will be a lecture about the treatment of insomnia. That's very important. Thank you.